Welcome to Spondyloarthropathies and Psoriatic Arthritis, Clinical Aspects and Treatment, number 5, Imaging of Spondyloarthritis. We're at the end, or close to the end, everybody. But we saved the best for last. So I'll ask my colleague, Xenophon, to introduce the first speaker.
Thank you very much, Michael. Good morning also from my side. We are starting the session by a presentation by Tan and colleagues named Psychophysical Joint Fusion in Ankylosing Spondylitis assessed using CT, associations with syndesmophytes, and spinal motion.
Okay. So this is a talk about psychophysical joint fusion in ankylosing spondylitis and how it relates to syndesmophyte and spinal motion. So none of the authors has any associated commercial interest. So in AS, spinal fusion can occur between vertebral bodies via syndesmophyte or in the posterior elements via the ZJ joint. So traditionally, both have been studied using radiography. So for syndesmophyte, radiographs have limited visibility, but it's good enough at the anterior corners to allow for semi-quantitative scoring, such as the MSAS. But for the facet fusion, it's much harder to see. But we have initiated work on AS using computed tomography. So things are quite different there. You have excellent visibility for syndesmophyte, and that allows you to fully quantify them, for example, in terms of height or volume. For the ZJ joint, you have excellent visibility, but it's still not readily quantifiable. So little is known about the ZJ joints because they are difficult to visualize on radiographs. But since we are using CT, we have a unique opportunity to investigate them. So there are two questions we want to ask. It's what is the relationship between the ZJ joint and the syndesmophyte and bridging? In particular, which comes first? And also, what are the relative contributions of ZJ fusion and syndesmophyte in relation to limited spinal motion? So here is how we quantitate the syndesmophyte. So here we show an example of one punctual measure of height. So you divide the height of a syndesmophyte by the height of the IDS. So that gives you a number between 0 and 1, 0 meaning no syndesmophyte, and 1 meaning bridging. So to get the complete picture, you have to do that all over the rim. So it's 360 degrees. So you have to repeat that. And for example, here we repeated the measure of height in 72 angular sectors. Each angular sector has 5 degrees. For evaluating ZJ fusion, we used the readings of 2 physicians. So the scans were anonymized, and then we also erased digitally the vertebral bodies so that the physicians could not be influenced by whether there was or not syndesmophyte in the vertebral bodies. So we had 2 readers, and we analyzed 6 vertebral levels from T10, T11 to L3, L4. Initially, we had a 3-category scale: normal, abnormal, but not fused, and fused. But we only had moderate agreement using this scheme, so we switched to a 2-scheme two category reading, and fused and not fused, and for this we had a very good agreement. So we had 55 patients. The mean age was 45 years. The mean disease duration was 18. Mean Schober test 3.5 and lateral flexion 13. So here are some examples of the joint seen on CT. So on this column you have people which are considered non-fused, and here people considered fused. So we go down, and you can see that the aspect of the joint changes as we go down. So here are the lumbars, fused and not fused. So we found that fusion was pretty common. About half of our patients had some fusion. And so the median number of vertebral levels with fusion was 1. Fusion was most often bilateral and contiguous. So in more than 70% of cases, if one patient had ZJ fusion at one level, he had fusion at the upper level too. So here are the prevalence by level. So I think the striking thing here is that in the first 3 levels, you have about the same numbers, about 35. But then when you go down, it drops pretty dramatically, and you're left with about less than 15. So you have more fusion in the upper levels. So here we consider the question of the relationship between synesmophyte and ZJ fusion, the question being which comes first. So we considered each individual level, and we sorted them out in 4 categories. The 4 categories are without fusion and without synesmophyte, with fusion and with synesmophyte but without fusion, without synesmophyte, and with ZJ fusion. So if you look at the numbers, the most common configuration is vertebral levels with synesmophyte, but without any ZJ fusion. And if you compare and the converse, which is some levels with ZJ fusion, but without synesmophyte, is very rare. So we can so this suggests that synesmophyte occur first. So we did the same with ZJ fusion and bridging. And here, the most common configuration are on this diagonal, meaning that you have the same status for bridging and fusion. So this suggests that bridging and fusion are more synchronous with each other. But if you look at the other diagonal, you can see that you have more levels with bridging but without fusion, ZJ fusion, than levels with ZJ fusion but without bridging. So you can say that this suggests that bridging is probably occurs before ZJ fusion. So then we looked at the correlation between ZJ fusion, synesmophyte, and bridging, and with Schober test and lateral flexion. And you can see that the strength of the correlation is about the same for all the measures, and all the P values are also very low. So now we look at the question of which one contributes most to limitations in motion of a spine. So first we consider forward flexion, which is the Schober test. So we used a multiple regression analysis, The dependent variable is the Schober test, and the independent variables are the number of fused level per patient and the total circumferential syndesmophyte height. So the beta were standardized to make the two variables comparable. And you can see that for the Schober test, for forward flexion, the two variables have about the same strength and the same p-values. So ZJ fusion contribute about as much as syndesmophyte to the limitations of spinal forward flexion. So now we did the same for lateral flexion. And you can see that there is some difference in the strength and the p-value. So you can say that ZJ fusion contributes somewhat less than syndesmophyte to lateral flexion. So in conclusion, so these are the main conclusions. So ZJ fusion is pretty common in AS. More than about 50% of patients had any ZJ fusion. Syndesmophyte and even bridging probably occur before ZJ fusion. ZJ fusion contributes as much as syndesmophyte to limitations in forward flexion, and somewhat less than syndesmophyte to lateral flexion. So based on this, based on the fact that syndesmophyte occur earlier and have a stronger association with limitations in movement, syndesmophyte should probably remain the main measure of spinal fusion in AS. So that's it. That was a bit short.
Thank you very much for this nice data. The abstract is open for discussion, and we see the first question coming up. Jürgen.
Able to differentiate post-inflammatory from degenerative changes by your method? And is it not much more probable that you influence spinal mobility if you have several fusions in a row? If you just look at one segment, this is less probable that you find a big influence, I think.
So the first question was whether you could nicely and well differentiate between syndesmophytes and spondylophytes, degenerative from post-inflammatory fibers.
I think so, because the osteophytes, they grow mainly laterally, and the algorithm only... yes, some of our patients do have the osteophytes that grow laterally.
Which were not scored?
No, they are not scored.
Okay.
And the second question was, what about the contribution of multiple levels to the clinical findings, or is it just one level that's important? How were you able to adjust that?
I don't think we did that thing. We took into account all the levels, so I don't think we did.
Well, I think you need to do that, right? Have
Yeah,
a suggestion.
Probably. Yeah, probably.
Okay.
Yes, we did.
I would have a question. You also had x-rays of these patients or no x-rays?
Oh, yes, we had X-rays.
Have you seen whether the x-rays show a different result to this means the syndesmophytes to limitation of mobility? Of course, you cannot score the facet joints, but could you see whether or not the result would be different when you would consider only the x-rays apart from the CTs? Because obviously we do x-rays in daily practice and not CT.
Yeah, we didn't do that experiment. We should probably do it, but we didn't do it here.
Another question?
Did you have problems to get this to the ethical committee to have X-rays and CTs in parallel?
No, we didn't have, it was below the threshold set by the NIH. I think it was, we had 8 millisieverts of radiation for each patient, and it was below the recommended limit.
Okay.
The radiation was below the recommended limit.
Yeah.
All right.
Good. If there's no other question, thank you very much.
Thank you. The next talk, come up. Adding MRI of the spine to the ACES classification criteria for axial, axial spinal arthritis, redundant or beneficial, results from the SPACE cohort. Dr. Ezzatuni is going to give the talk.
Thank you.
It's all yours.
Thank you for the introduction. I have the great pleasure this morning to present our most recent data on adding the MRI of the spine to the ACES classification criteria. And I have no disclosures. So the past few decades, we have seen an increased role of MRI in the field of spondyloarthritis, not only in clinical trials, for example, but also in the diagnostic workup of chronic back pain patients. Currently, the ACES classification criteria only use imaging of the sacroiliac joints, which I will show you right now, is that there has to be either sacroiliitis on X-rays, or there has to be an active inflammation on MRI in the sacroiliac joints to classify patients in the imaging arm of the ACES criteria. So we know that spinal inflammation does occur, and therefore the ASOS group has made a consensus definition of a positive MRI of the spine. And we have also seen in recent papers that spinal inflammation does not only occur in the presence of inflammation in sacroiliac joints, but we have also seen that it also does occur without inflammation in the sacroiliac joints. Therefore, we wondered whether there is an additive role for a spinal MRI in SPA. And what we have, as objectives is first to analyze the prevalence of spinal inflammation on MRI in patients with chronic back pain. Secondly, we wanted to see what the yield is of adding MRI of the spine to the ASOS classification criteria as an imaging criterion. And thirdly, we investigated the influence of the usage of different definitions of a positive MRI of the spine. We have done this investigation in the SPACE cohort, and the SPACE cohort is a European study which includes chronic back pain patients with recent onset, and all patients undergo a full workup, meaning that all SPA features are assessed, laboratory investigations are performed, and of course, imaging of the sacroiliac joints and the spine. For the purpose of our objectives, our research questions, we use the central reading of these patients, meaning that baseline MRI of the sacroiliac joint and the spine, STIR-NT1 sequences, were independently scored by 3 well-calibrated readers and blinded for all other data. Furthermore, all imaging were considered positive if 2 out of 3 readers agreed. So for the definition of a positive MRI of the spine, I will go through the slide, which is kind of busy. But first off is lesions were only scored if they were suggestive or highly suggestive of inflammation. And the reader scored, firstly, according to the ASES consensus definition, which states that an MRI of the spine is positive if at least 3 bone marrow edema lesions are present on at least 2 consecutive slices in the entire spine. The second definition is what I call the rule of 5, which has been recently published in the Annals of Rheumatic Diseases by De Hooge and colleagues, which states that there has to be a minimum of 5 bone marrow edema lesions, each visible on at least 2 consecutive slices. This cutoff value has shown to be quite discriminative between no axial SPA and SPA with a specificity of at least 95%. The second, or the third and the fourth definition of a positive MRI of the spine is done using the SPARC method. And the SPARC method is a method in which all corners in all 23 vertebral units are scored, including the depth and intensity on 3 consecutive slices. We have used this score because in most papers the SPARC score is also used to define inflammation. So the first definition using the SPARC score is the score of at least 5 by at least 2 readers. The second definition of a positive MRI of the spine is that there has to be a SPARC score of at least 5 by a mean of 3 readers. So I have brought with me a few examples of bone marrow edema lesions in the spine, and here you can see a circle around it that there is inflammation in the lower corner. And I will go through the consecutive slides. You see, I will show you here. You see some inflammation here, slightly a spot, which I think would not be scored. But this is a good example of also bone marrow edema lesion. And these are other examples. Of course, we have also scored the sacroiliac joints, and again, only lesions highly suggestive of inflammation were scored, and a positive MRI of the SI joint was defined according to the ASAS definition. And here again, some examples of T1 and STIR image of the sacroiliac joint, in which you can see clearly the bone marrow edema lesions, and you can see at the arrows which ones. Additionally, we have also scored the X-ray of the pelvis, and they were all scored according to the modified New York criteria. Of course, we have used the ASAS classification criteria to classify these patients, and importantly, all imaging modalities were scored independently of each other. So in total, we had 541 patients at baseline which could be scored and had available imaging. And we see that around 34% of these patients were male with a mean age of 29 years, so young patients, and around 39% was HLA-B27 positive. So what I will do with you now is go through the results, and we have made flowcharts to demonstrate as clearly as possible what the yield is of a positive MRI of the spine within our cohort. So the first definition I will go with you is the SPARC score of a minimum of 5 by 2 readers, so the positive MRI of the spine. So we see that we have 541 patients with available X-rays, which I just stated. 501 of these patients had no radiographic sacroiliitis, and of these patients, 447 patients, or 447 did not have inflammation on MRI. Would we perform an MRI of the spine of these patients, we see that 21 of them had a positive MRI of the spine according to this definition, meaning that 447 MRI of the spine had to be performed to catch, let's say catch, these 21 patients with an MRI, positive MRI of the spine. The second definition is a definition which states that there is a positive MRI of the spine by a SPARC score of at least 5 from the mean of 3 readers. So again, you can see the first numbers, of course, stay or remain the same. And we see that of the 447 patients without sacroiliitis, 13 patients were additionally caught by a positive MRI of the spine. Again, the same conclusion, 447 MRI of the spine had to be performed to catch these 13 patients. So now we go through the already known definitions. The first one is the ASAS consensus definition. So this states that there has to be at least 3 bone marrow edema lesions on at least 2 consecutive slices. So the first numbers, of course, remain the same, and we see that of the 447 patients without sacroiliitis, 5 patients had a positive MRI of the spine. Again, 447 MRI of the spine had to be performed to catch these 5 patients. Would we use the rule of 5, stating that there has to be at least 5 bone marrow edema lesions? We see that only 3 of these patients were caught additionally by a positive MRI of the spine. So our second research objective was, of course, to see What would happen if we would add a positive MRI of the spine to the ASUS classification criteria? So what we have done is we have outlined every definition in this table, and I will go through this table with you. So first you can see the definition of a positive MRI of the spine, which states that there has to be a SPARC score of at least 5 by at least 2 readers. The second column is at least the SPARC score of at least 5 by the mean of 3 readers. Then the ASUS consensus definition, and the definition of the rule of 5. So in the first row, we can already see that the patients who were already classified by the clinical arm of the ASUS criterion, meaning these patients were HLA-B27 positive and had at least 2 additional SPA features. So we see that a majority of these patients were already classified through the clinical arm. If we look at the second row, we see the patients who were additionally classified by the imaging arm through the addition of a positive MRI of the spine to the criteria. So we see that 62% of these patients were additionally classified. In the second group, we see that 46%, then 40% in the ASUS definition group, and 33%, well, 1 patient in the rule of 5 group. So most importantly, all these patients had, of course, at least 1 SPA feature. You see that in the first group, most patients had at least 2 SPA features, but if you look at this row, it's kind of comparable. I haven't put it in this slide, but I think it's important to know that most of these patients had SPA features such as good response to NSAIDs, a positive family history of SPA, elevated ESR or CRP. So there were kind of, let's say, weak SPA features. So in conclusion, in this cohort of chronic back pain patients, of young chronic back pain patients, a positive MRI of the spine was rarely seen, and also was rarely seen in the absence of sacroiliitis on MRI. We have seen that adding a positive MRI of the spine as an imaging criterion to the ASUS classification criteria had a low yield in number of classifications, as shown in the table before. We have used those SPARC-based definitions to just explore what the additional value of this would be, and we see that they included the highest number of additional patients. Most importantly, as I've just mentioned before, is that most patients had a low probability of having actual SPA because of having more or less the weak SPA features, such as good response to NSAIDs. So what we like to summarize or conclude is that performing MRI of the spine at baseline in this case is of little value in the classification of chronic back pain patients with a short duration and a suspicion of actual SPA. I would like to thank all participating patients, the centers, of course, the researchers, and the Dutch Rheumatism Foundation. Thank you.
Open for questions?
Did you also have the chance to check for diagnosis of axial spondyloarthritis in these patients?
Yes.
So when they were MRI spine, before you did the MRI spine investigation, did they already have a diagnosis of axial SPA, and did it change somehow, or didn't you check for this?
Well, what we don't have is the diagnosis before only MRI spine has been performed. What we do have is the diagnosis of the rheumatologist before imaging was performed, and also the level of confidence about the diagnosis. And what we have also is the diagnosis after all imaging were performed. So that includes the MRI of the spine as well. So it's really hard to tell whether a rheumatologist was convinced by the MRI of the spine specifically.
Was there any patient in whom the MRI spine was positive who did not have a diagnosis of axial SPA?
Yes, we have that. Yeah, definitely. Yeah.
Thank you for the nice data. I wonder whether there is an agreement. How many MRIs of the spine would be due to make a diagnosis in one?
I'm sorry, how many MRI of the spine should be performed?
It's probably not to be answered, that question. It's just, what would be our if you want financial input, if that would contribute. How many would we do to make a diagnosis in one? I mean, the background of this study is, I think, the ability publication, where it was shown that many patients had spinal inflammation by MRI in the absence of sacroiliac inflammation. Mm-hmm. So this is different because I think the patients were younger. But it's a conceptual question.
Well,
how much would we invest?
Well, we have done this study to see the yield of, to look at the yield of the performance of an MRI of the spine. And I would say we have used the classification criteria because we couldn't use the diagnosis, because we don't know based on what information the rheumatologist has diagnosed the patient. But I would say performing an MRI of the spine, why would you do it? I would say for diagnosis, I don't think we need to perform MRI of the spine for diagnosis. I think we should stick to sacroiliac joints. So that's kind of a bold statement, I know, but yeah. Yeah.
Okay, one more very small question or short, maybe also a short answer. Do you think that it's rather a cohort-specific finding that you find so, let's say, low numbers of patients being positive? If I read it correctly, also the number of patients with a positive MRI of the sacroiliac joints was pretty low.
Yes, yeah. Well, what we have is, I haven't brought these data with me, but we have done these analyses in the DESIR cohort as well. And these patients have a longer disease duration, but they are quite early axial SPA as well. And we see actually the same percentages of a positive MRI of the SI joints and MRI spine. So, yeah. It's for these two cohorts, but yeah.
Okay.
Okay, thank you very much.
The next abstract is going to be presented by Polacek and colleagues. It's entitled The Association Between Sonographic Enthesitis and Radiographic Damage in Psoriatic Arthritis.
There you go.
Okay, so good morning. I would like to thank the organizing committee for choosing this study for oral presentation. The title of the study is The Association Between Sonographic Enthesitis and Radiological Damage in Psoriatic Arthritis, and this study was done while I was a clinical and research fellow in the Toronto Psoriatic Arthritis Clinic. These are my disclosures. The musculoskeletal involvement in psoriatic arthritis can affect different locations, such as the synovium, bone, fat pad, bursa, adjacent tendon, and enthesis. Enthesitis is a unique feature of the spondyloarthropathy group in general, and of psoriatic arthritis in particular. And a few studies that compared rheumatoid arthritis to psoriatic arthritis patients demonstrated this point, showing synovitis in both rheumatoid arthritis and psoriatic arthritis patient, whereas enthesitis was demonstrated mainly in the PSA group. Recently, a few studies across the world, including Brazil, Japan, and one from our center in Toronto, Canada, evaluated the presence of clinical enthesitis in large PSA cohorts. And the conclusion from all of them was that clinical enthesitis is a common finding occurring in about a third of PSA patients. Besides physical examinations, there are a few imaging modalities that can assist in enthesitis assessment. The first option is the conventional radiography modality. This modality can show enthesophytes and erosion. The main downside of this modality is that it shows mainly chronic retrospective damage. The second modality is the MRI, and although it is considered the most advanced modality, a recent trial evaluating enthesitis by an all-body MRI showed an enthesitis prevalence of only 17%, while the readability for some locations as shoulder, hip, and pelvis was very good. For other enthesial points, it was low, and hence further study is required before clinical implementation. And this leads me to the ultrasound, which emerges as the preferred way to assess enthesitis. It is cheap, available, and relatively easy to perform. Several studies that compared ultrasound and physical examination showed that ultrasound had higher sensitivity and specificity in detecting enthesitis compared to physical examination. And finally, in this introduction, there is the debate on whether enthesitis is the primary lesion that triggers the related inflammation in the adjacent synovial joint. This is based on the synovial enthesial complex model, which was suggested by Dennis McGonigal from Leeds, England. And you can see the physical proximity between the enthesis and the synovium. Actually, there is one small study from Italy that may support this theory. This study showed that 23% of the patients with psoriasis progressed to psoriatic arthritis over a period of 3.5 years. The main predictor for progression was sonographic enthesitis of the quadriceps tendon. And hence, the aim of our study was to examine the association between sonographic enthesitis and the severity of radiographic features of joint damage in psoriatic arthritis. A cross-sectional analysis was conducted in patients from the Toronto PSA cohort. Patients were diagnosed as having PSA according to the Caspar criteria were included. Patients were assessed clinically with complete history and physical examination, including clinical assessment of different enthesial points according to the Spark index. This is the ultrasound device that we used. Reading of the ultrasound scan was performed independently of the clinical data by a single reader. The MASI. At this point, I would like to clarify and maybe apologize, as some of you might be disappointed, but I am not going to speak on this guy, Messi from Barcelona, but rather on MASI from Madrid. So the Madrid Sonography Enthesitis Index scoring system was used to assess and quantify the extent of sonographic enthesial abnormalities. This index includes 12 enthesial points which are located adjacent to large joints. This index includes two subcategories. The first one on the left side is the soft tissue score, which include increased thickness, bursitis, and vascularization, which is assessed by the Doppler. And the second one on the right side is the bone score, which include enthesophytes, calcifications, and bone erosions. Radiographic joint damage in the peripheral joint was assessed by the modified Steinbucher score, and radiographic damage in the axial skeleton was assessed by the modified New York criteria for sacroiliitis and the modified Stock ankylosing spondylitis spine score, or MSAS, for the spine. Several statistical tests were performed. Descriptive statistics are provided. Linear and logistic regression models were used to assess the association between MASI score and the radiographic features of joint damage. Each regression model was adjusted for age, gender, BMI, PSA duration, DMARDs, and biologic cues. The Pearson correlation test was used to assess the correlation between MASI score and PSA-related variables. And the results. 222 patients were included. 58% were male with a mean age of 56 and a mean PSA duration of 16.7 years. The mean tender joint count was 2.4, the mean swollen joint count was 1.1, and 13.5% had clinical enthesitis. The mean MASI score was 15.6, the mean modified Steinbucher score was 18.1, the mean MSA score was 1.7, and 37% had sacroiliitis. Multivariate regression analysis showed an association between higher MASI score, which reflect more severe sonographic enthesitis, and the modified Steinbucher score. Similar association was demonstrated between the MASI bone and soft tissue subcategories and the modified Steinbucher score. In addition, an association was demonstrated between the MASI and joint ankylosis. The MASI bone and MASI soft tissue score were associated as well with joint ankylosis. And finally, in the peripheral radiographic damage section, an association was demonstrated between higher MASI score and arthritis mutilans. In this case, only the MASI bone score was associated with arthritis mutilans, while the soft tissue one was not. Moving to the axial radiographic damage, multivariate regression analysis showed an association between higher MASI score and sacroiliitis. The MASI bone score was associated with sacroiliitis, while the soft tissue score was not. And there was a positive association between higher MASI score and the MSAS. Both the MASI bone and soft tissue score were associated with the MSAS. Last but not least, the Pearson correlation test showed a significant positive correlation between the MASI and damaged joint count, dactylitis, PASI, and acute phase reactants. while it wasn't correlated with the swollen and tender joint count. In summary, MASI was associated with each peripheral radiographic damage variable, including modified Steinbucher score, joint ankylosis, and arthritis mutilans. It was also associated with each axial radiographic damage measure, including sacroiliitis and MSAS, and the MASI was correlated with clinical damage joint count, PASI, and acute phase reactants. This study has a few limitations. It is a cross-sectional study, and hence we can't infer on causality. Treatment effect may have modified relationship as we controlled for treatment only at the time of assessment. And there is no consensus on a single ultrasound index for enthesitis, though we think that MASI is the better option since it includes sites in both the upper and lower musculoskeletal system, and it used the Doppler to assess vascularization. This study has a few strengths. As far as we know, this is the largest ultrasound enthesitis study in psoriatic arthritis. Our cohort is well characterized, which enabled to control for multiple confounder, and the base for enthesitis diagnosis was the ultrasound, which is more accurate than physical examination. And the conclusion would be, the severity of sonographic enthesitis is a marker of radiographic peripheral and axial joint damage in psoriatic arthritis. This association was found with both destructive and bone formation lesion, and hence, this finding highlights the potential role of enthesitis in the pathogenesis of articular damage in psoriatic arthritis. And I would like to thank the wonderful PSA in Toronto for the great support and help.
Thank you very much for this nice data. The abstract is open for discussion.
If you allow me, I want to add a limitation to your study, because what you have shown is a high number of statistically significant but clinically totally irrelevant associations. Especially your first conclusion, I think, does not give justice to what you found, because there is almost no association. It's statistically significant, but the correlation coefficients were so poor and the odds ratio was so low that I presume it does not have any clinical impact.
Well, I'm not necessarily agree with you, and I do think that the ultrasound finding that we see while we are doing the ultrasound do have meaning, and there are studies that show that the ultrasound is more accurate than clinical assessment. Although I do agree with you.
If you want to make that point, then please explain to me what it means that you find an odds ratio of 2, for instance, between MASI and some clinical outcome. What is the impact of such an odds ratio?
I think that it shows that there is an association between the two things.
I agree with you, a statistically significant association, but it doesn't mean anything in terms of impact.
I think that it does show an impact on...
But please explain to me.
This was what we showed in these studies, I think.
This was what the model showed. Thank you.
Okay, any other question?
Let me ask you, and perhaps I missed it in the presentation, but what was the relationship between the clinical physical finding of enthesitis and the ultrasonography finding of enthesitis? Was there a relationship between the two?
No, there was no relationship, but we should realize that clinical enthesitis was assessed by the SPARC index, and the ultrasound was assessed by the MASI. And although there is an overlap in some points, these points are not the same. And actually, I think this is not a surprise, because ultrasound shows more finding than a clinical assessment, and previous studies that evaluate the relationship between ultrasound and physical examination show low to moderate association between the ultrasound and physical examination finding.
Is there any value in the physical examination of enthesitis, really, from your experience in this study and your review of the literature? Is there any value to that, to the physical examination of enthesitis? This has always, in my mind, been some sort of a controversial area.
Well, it's a great question, and I think that there is a discrepancy between what we see clinically and what we see by imaging modalities. But I think that currently, most of us don't do ultrasound and most of us don't have MRI. So currently, speaking bedside, this is the most available tool that we have, and we need to practice it and try to do the best with what we have.
All right.
Okay, thank you very much.
Thank you. Our last presentation, scoring syndesmophytes on CT scan images of patients with radiographic axial spondyloarthritis from the sensitive imaging of axial spondyloarthritis cohort, and Desiree will do the presentation.
Thank you very much for the opportunity to present our data on CT scan. So we're going back to the same topic as the first presentation, the CT scan of the spine. There are no personal disclosures of any of the authors, and the study was founded by the Dutch Rheumatism Association. We know that the conventional radiography is the standard for the assessment of structural damage in the spine of patients with ankylosing spondylitis. We use the lateral, lumbar, and cervical spine because those are the images that can be assessed reliably. The MSAS is usually the preferred method, and that is mainly based on syndesmophytes. However, a limitation is that it takes about 2 years to find progression in a substantial amount of patients. CT scan is the imaging of choice if you want to evaluate bony structures. The advantages of the CT, that this is a really fast method. In 40 seconds, you can image the whole spine. The multi-slice CT enables you to have multiplanar reconstructions. However, the big disadvantage is the high radiation dose, which is about 8 to 10 millisieverts. Using an adaptation of the scan protocol can lower the dose with still an acceptable image quality. The dose of radiation for the whole spine with this adapted protocol is 2 to 3 millisieverts, which is equivalent to about 1 pelvis, 1 lateral, lumbar, and cervical spine image. And this makes the low-dose CT scan of the whole spine a viable and possibly more sensitive imaging method to assess the bony structures of the spine. So the purpose of this investigation was to develop a scoring method to assess the syndesmophytes on the CT scan of the spine in patients with ankylosing spondylitis. And we wanted to test the inter-reader variability for this newly developed scoring method. 2 centers were participating in the study, one in Leiden, the other one in Herne, and we had a prospective 2-year follow-up study of patients with ankylosing spondylitis. The inclusion was based on the following. All patients fulfilled the modified New York criteria. They needed to have at least 1 syndesmophyte on either the cervical or lumbar spine on conventional radiography, but there should be a maximum of 18 out of the 24 different edges, so that we could still observe some progression. And there was a requirement that there should be an amount of inflammation on MRI of the spine, but that no minimum was specified. There was no specific level of clinical disease activity required, and all treatments were allowed. Then at baseline and after 2 years, we had radiographs of the lateral, lumbar, and cervical spine, a CT scan, the low-dose CT scan of the whole spine, an MRI of the whole spine, and we also had that after 1 year. The current analysis of this presentation is based only on the baseline and 2-year data of the CT scan. We had coronal and sagittal reconstructions, and 2 readers scored independently, blinded for time order, the CT scans per patient. So we had a sagittal view, a coronal view, and the syndesmophytes were scored in the coronal and sagittal planes for all corners per view, so in total scoring 8 quadrants per vertebral units for the entire spine. So we have 23, so the scoring was absent, then it was 0. If there was a syndesmophyte which was less than 50% of the intervertebral disc height, it got a score of 1. If it was at least 50%, then a score of 2. And if there was fully bridging, it was a score of 3. That means that the maximum score in 23 vertebral units with 8 quadrants per unit and 3 points per quadrant sums up to 552. So here we have an example where you have in the big arrowheads, you have a score of 1, as it is the syndesmophyte of less than 50%. Here we have a score of 2, where it's more than 50%, but still not bridging. And here you have a score of 3. In total, we had 56 patients. 84% of them were male, the mean age close to 50, and 80% of them were HLA-B27 positive. On the normal radiographs, there was a median of 4.5 syndesmophyte. Here are the scores of the 2 readers at baseline. What you see here is all 23 vertebral units, the cervical spine, the thoracic spine, and the lumbar spine. These are the scores for reader 1, these are the scores for reader 2, and this is the percentages of patients that have a specific score in that vertebral unit. So if you just look at the global score, you see that both readers saw very similar abnormalities. If we then check in detail, you can see that most abnormalities were seen in the thoracic spine. So the dark green is that 50%, for example, at this level, 50% of the patients had a bridging syndesmophyte at this level. The bridging syndesmophytes were mainly in thoracic spine and to a lesser extent in the cervical and lumbar spine. The non-bridging syndesmophytes were also frequently in the lumbar spine, and the smaller syndesmophytes were not observed very frequently in this cohort. So here you have, again, a typical example where you have the white arrows, you have the 3, the bridging syndesmophyte, and the magenta score is a 1 and a 2 at this site. Then here are the data of the 2 readers. They are split again for the whole spine with a maximum score of 552, the cervical, thoracic, and lumbar spine. These are the baseline data and the year 2. And you see that the median and range for reader 1 was, for all measures, relatively close to the median and range for reader 2. If you look at the ICCs for the status score at both baseline and follow-up, these were very high for the 2 readers. You again can see that the highest scores are seen in the thoracic spine. Also, if you correct for the number of vertebral units that you have in the thoracic spine in comparison to lumbar and cervical spine. And the second most prevalent site for the syndesmophytes is the lumbar spine. But most interesting is probably the change scores. So if we check the change over a 2-year period, the median change of the whole spine is 9 for reader 1, 8 for reader 2, with a big variation, and also the ICC for change scores is rather good. We also calculate the smallest detectable change based on the inter-reader reliability. For the whole spine, this is 12. And if you apply that, then 34% of the patients showed progression over a 2-year period above the SDC. So you already take the measurement error into account. In the cervical spine, there's 16% of the patients, the thoracic spine only 27%, and the lumbar spine 25% of the patients. If we check where that progression is happening, then you see again that both readers, they identify the progression in a very similar pattern. And also here, you see that there are various levels, especially in the thoracic spine, where up to 40% of the patients, they show any progression at that individual level. So in conclusion, we developed a fine-grained scoring method for the CT scan of the spine. There was good accuracy for scoring the syndesmophytes between 2 readers. The thoracic spine, which is usually not included in the assessment of structural damage in patients with ankylosing spondylitis, holds a lot of information. And also, progression was picked up in this part of the spine in a high percentage of the patients. The next step will be the comparison with the MSAS. We have the data available also for all patients with the MRI, and also the evaluation of the same methods in patients with early disease. Finally, I'd like to thank all patients that participated in the study and the Dutch Rheumatism Association for the grant. Thank you.
Desiree, before we ask for questions from the audience, I have a brief question. From a physiologic or pathophysiologic standpoint, why would you suppose that bone growth would be the most rapid or maximal in that part of the spine, the thoracic spine? Do you have any thoughts? Speculate on that a little bit.
It's really speculation, but it could be the force on the spine, because we think that is probably a combination of mechanical stress and inflammation and the reparative tissue, which is causing the bone formation.
All right, the front, Walter?
So I think that what I'm particularly interested to know about is not so much bone growth, but the development of new syndesmophytes. Because when we look at therapeutic interventions, we're looking at ameliorating inflammation and preventing the development of new syndesmophytes. And then the pathophysiology of bone growth is quite different. But there we're looking at a very different therapeutic approach where we're really aiming to do something about bone proliferation. So what I would also want to know is, I mean, this looks very encouraging and it's an excellent presentation, but that's one aspect of the scoring that would be of particular interest to me. How reliably do the readers detect new syndesmophytes?
That's a very good suggestion that can easily be calculated, but I don't have the data ready now. But next time we will meet, you will get it.
Had you also
a very short question and short answer.
Had you also considered doing CT after 1 year? Because if it's more sensitive, might be easier to have a control group for 1 year.
We definitely did consider that. We even asked the ethics board for it, but at that time, this is a study that started several years ago. They did not allow us to do it after 1 year.
Second question, might it be an option to go only for the thoracic spine? Would this lower the radiation exposure?
It will lower the radiation exposure, but then I would prefer to have the whole spine so that you do not need anymore the lumbar and cervical spine, but for the whole spine you definitely get more information than only thoracic spine.
All right, I think we've reached the end of the session. For other questions, please come up and discuss them directly with the speakers. Thank you very much. Thank you, Desiree.
Good job.